Hi, this is Zach Fulkerson with the Critical Care Curriculum. Today we are going to be talking about hypercapnia. This is one type of respiratory failure, the other, of course, being hypoxemia. As a reminder, some of the normal ranges, pH 7.35 to 7.45, PCO2 or carbon dioxide is around 40 in the arterioles, in the arteries and arterioles, and bicarbonate is around 24. The anion gap is somewhere in the neighborhood of 12. We go into more detail with these in the acid-base lectures. Let's talk really quickly about the causes of hypercapnia. So CO2 is produced in the tissues when you break down, say, glucose during the normal metabolism. It travels through a pulmonary capillary and diffuses into the alveolus. When you take a breath in, you're actually breathing essentially zero carbon dioxide. And I know this isn't exactly true because there's always a little bit of rebreathing and a little bit of carbon dioxide in the atmosphere, but for all intents and purposes, it is zero, which means that you have a huge gradient for carbon dioxide to diffuse from the blood into the alveolus, and it will do this until they equilibrate. Now, there won't be any more diffusion until you take a breath out and then you breathe in and the process starts all over. So, how can things break down? I've drawn a little diagram to show you carbon dioxide being produced from the mitochondria, going through the tissue into the blood, circulating through the body, circulating through the lungs, and then finally breathing out in the airways. And so, problems with each of these pathways can cause an increase in CO2. You can have decreased minute ventilation because of a problem with your lungs. You can have increased dead space because of poor pulmonary perfusion. This is when you have alveoli that are being ventilated but not perfused. That's what dead space is. You can have an increase in carbon dioxide production, which occurs at the tissue level. We can break down minute ventilation into people who won't breathe and people who can't breathe. So these are people who, from some neurological reason, will not breathe, and these are people that mechanically or because of some problem with their lungs cannot breathe. To dive into this even further, let's go through some examples. So people who won't breathe, this includes people with an overdose, especially opiates or benzodiazepines, people with obesity, hypoventilation syndrome, hypothyroidism, so myxedema coma, for example, a metabolic alkalosis, so you lose your drive because of an alkalosis, or something going on in the central nervous system, such as stroke or encephalitis. This is to be contrasted with people who cannot breathe, say, for instance, paralysis. So maybe someone got a paralytic agent such as rocuronium, or maybe they had an upper cervical injury from an accident like a motor vehicle accident, and they physically cannot breathe because of paralysis. You can also have neuromuscular weakness from things like ALS or Guillain-Barré syndrome or myasthenia gravis that can cause people to not be able to breathe. Thoracic cage disorders, this is one that's often overlooked, but someone with severe scoliosis or kyphosis or another thoracic cage disorder. COPD, hyperinflation from COPD can actually mechanically make it so you cannot get a big breath in. Same thing is true for asthma, especially in people with severe asthma attacks. They hyperinflate and physically are not able to get large volumes in because they cannot exhale. I've included these both with dead space because emphysema as well as increased alveolar pressure can actually increase alveolar dead space, so that's why I've included these kind of in the middle here. And interstitial lung diseases will do the same thing, so they make it restrictive so you can't breathe, and they also increase dead space. There aren't a whole lot of things that increase dead space on their own. If you have someone who is on a ventilator and you are giving them too high of a volume, you might over-distend their alveoli and increase dead space. Having too much ventilator tubing can increase dead space. Someone who's not ventilated but shallow breathing can increase dead space, and this is because whenever you take a breath in, you have some minute ventilation and also some dead space ventilation. So if you're doing rapid shallow breathing, you have a higher proportion of dead space ventilation. CO2 production, this can be sepsis, this can be thyrotoxicosis, so here we're going into the opposite of hypothyroidism. And then finally, metabolic acidosis. And this is really because in a metabolic acidosis, you're trying to buffer that metabolic acidosis using bicarbonate. And when you do that, you produce carbonic acid, which is broken down into water and carbon dioxide. So what are the symptoms of hypercapnia? Well, at the beginning, you have people who look uncomfortable. They're in respiratory distress. They have increased work of breathing. They're anxious. This is very common in someone who's, say, having a COPD exacerbation, or someone in a myasthenic crisis, or someone who is having an asthma exacerbation. However, as the CO2 starts to build up in their system, something happens in that they become altered. Their respiratory drive actually starts to go down because of their altermentation. They will actually go into a comatose state eventually. They could potentially have seizures from cerebral edema, and this essentially creates a positive feedback loop where things can worsen and worsen and worsen. Something that you will see very commonly is this little myoclonic jerk in their hands that very often happens. It's kind of like, it almost looks like asterixis. It's very common in hypercapnia. So I want to emphasize hypercapnia is a common cause of altermentation in hospitalized patients. This should be on your short list. Other things on your short list should be some sort of medication overdose, especially opiates, or hypoglycemia. But hypercapnia, if you are called to the bedside of someone who is altered, who's not responsive, this should be on your short list. You should be thinking about getting an ABG and an arterial blood gas on that patient. All right, first question of the day. Which medication can aid in reversing an overdose of benzodiazepines? Is it Sugamidex, flumazenil, naloxone, or an andexanet alpha? Our correct answer is flumazenil. Sugamidex is used by anesthesiologists to reverse paralytics such as rocuronium. Naloxone, also called Narcan, is used to reverse opiates. Flumazenil, benzodiazepines, and andexanet is used to reverse oral anticoagulants, some of the novel oral anticoagulants. As a note of caution, flumazenil can cause seizures, especially in patients with a history of seizures, maybe patients with a history of alcoholism, so use this with caution. So this gets us to the management, and really the main management is to try to address the underlying cause. So for instance, if you have someone in a COPD or asthma exacerbation, you're going to treat that. You're going to give them bronchodilators, you might give them corticosteroids. You might give someone naloxone for an opiate overdose. You might give someone flumazenil, again with caution because of that risk of seizures, for a benzodiazepine overdose. Other sorts of addressing the underlying cause might be IVIG for someone in Guillain-Barré, or corticosteroids in someone in a myasthenic crisis. Ventilatory support includes non-invasive and invasive. Basically, you have BiPAP and you have invasive. In general, oxygen is not going to help you out. In fact, oxygen, like a nasal cannula, can make things worse by lowering the respiratory drive. So this is the mask that fits over the patient's face. And this is, of course, actually intubating a patient, putting a tube into their trachea, and mechanically ventilating, helping them move air in and out. All right, last thing that I want to talk about is a fairly complicated problem, and that is to go through the effects of hypercapnia or hypoventilation on oxygen, because hypoventilation is actually a cause of hypoxemia, and the reason it is not necessarily intuitive until you go through this. So our problem is a young patient who is admitted for pain control due to malignancy. She has bone metastases, and she is receiving IV hydromorphone for pain relief. So she's getting an IV opiate. Her PaCO2 has been insidiously increasing. She has a normal alveolar arterial O2 gradient of 10, and the reason this is important, this is basically the difference in the partial pressure of oxygen in her alveolus minus her arteries. Normal's around 10. It tends to go up with age. So you're always going to have some sort of gradient. People with lung disease have a large gradient, and people who don't have lung disease have a small gradient, such as 10. Assuming the hospital protocols are to add supplemental oxygen when her saturation reaches 89%, at what point will someone finally say, oh, wow, I need to put her on a nasal cannula because her oxygen's low? At what point on a PaCO2 level will she be put on a nasal cannula? So a complicated problem. Some equations that are going to help you out is this equation, which is the AA gradient spelled out in mathematical form. So this is the arterial O2 equals the alveolar O2 minus 10. That's her AA gradient. This is called the alveolar gas equation, and that's where the oxygen in an alveolus equals the percentage of oxygen you're breathing in times the partial pressure of, times the atmospheric pressure minus however much water is there. So FiO2 times this difference minus the PCO2 divided by this thing called the respiratory quotient. This is basically how much CO2 molecules get produced for every oxygen molecule that gets consumed. It's normally about 0.8. I'm not going to go into it any more than it's normally about 0.8. We're going to use 765 for atmospheric pressure, and we're going to use 47 millimeters of mercury for the partial pressure of water. This is usually a constant because body temperature is usually fairly constant with people, and by the time air gets down to the alveolus, it is 100% saturated. So whether you're in the desert or in a really humid place, by the time air gets down to the alveoli, they'll have 47 millimeters of mercury of water in there. So we're going to use this equation. And we're going to use these numbers for your oxygen dissociation curve. Remember, I want to know the PCO2 at the point where she reaches an O2 saturation of 89%. So if we assume that there's no shifting of the oxygen dissociation curve, we're looking for a saturation of 89%. So probably want to use this number right here, 56 millimeters of mercury, when you're working out the problem. So again, your answer, what will her PCO2 be when her oxygen saturation reaches 89%? Is it 38 millimeters of mercury, 48, 58, or 68? The answer here is 68, and really quickly, if you need, I'm going to go through how to do this. So again, we've got the AA gradient right here. We have the alveolar gas equation. All I'm doing is plugging in numbers. This entire paragraph is the alveolar gas equation. Minus 10 will get me that PaO2. I'm interested in the PaO2 when it's 56. So I solve all of this for the PCO2, and these are just my steps. I'm not going to go through it in detail. You can feel free to pause it and look at my work a little bit more detailed, but essentially we are going to solve for PCO2, and by the time we do that, we get 68 millimeters of mercury, which is the correct answer. So note that her CO2 is really, really high before she's ever put on a nasal cannula and before you ever even realized something's wrong. Now, in a lot of places, a patient might get put on a nasal cannula and the doctor doesn't even get called. So let's assume that she was put on 2 liters, and this increases her FiO2 to about 28%. It's a good estimate. The nurse's call orders indicate that she only needs to notify you if she requires more than 2 liters. All right, so if you give her 2 liters, you don't even have to be notified as the physician. So by the time she gets to 2 liters, what will the PCO2 be by the time you get notified? So essentially by the time her oxygen's going down despite being on 2 liters or 28%. Is it 78, 88, 98, or 108? You're going to work this the exact same way as before, except instead of 21% FiO2, you're going to use 28% FiO2. So figure that out. If you've done your math correct, you should see that you will not even get notified that the patient's needing more oxygen. You won't even get notified until the PCO2 is 108. At this point, your patient is probably comatose. The point being is that hypoventilation absolutely is the cause of hypoxemia. Hypoventilation, of course, is related to high CO2 levels, and it is going to, in normal, healthy lungs, it will be a long time. You'll have very, very high CO2 levels before you ever see anything abnormal on the O2 saturation thing, which is the finger saturation monitor. So if you're not aware that this is a possibility, you could be finding out much, much later when the person is actually comatose, which again, if you're getting called to the bedside for someone who is comatose, who's altered, high CO2 needs to be on your short list of things that could be wrong with your patient. That does it for hypercapnia. In the next lecture, we're going to go into hypoxemia in more detail.